I'm the vice president of the International Association for Child and Adolescent Psychiatry for the South America. And as the vice president, I would like to welcome you to this Lunch and Learn webinar. This is an activity that IACAPAP promotes every 2 months. And this activity, this specific activity, is focused on South America. And this is because we are about to host the next World Congress of the International Association for Child and Adolescent Psychiatry in May 20 to 24 in Rio de Janeiro. We'll have this wonderful meeting. The scientific program is already online, so you can check that we have more than 20 international invited speakers, and more than 100 symposiums were submitting, giving space to people from all over the world. Nowadays, we have people from more than 100 countries already registered. And as we are following the registration rate, we are anticipating that this will be closed before the meeting. So if you are planning to attend the meeting, I strongly suggest you that you register now. And for this webinar, we will have the pleasure of having Dr. Ricardo Krause, who is the president of the Brazilian Association of Child Neurology and Psychiatry. Ricardo.
Thank you, Guilherme. Today, March 20, the International Day of Happiness is celebrated. And I'm particularly happy to be here, to be the chairperson of this webinar, ADHD in the First Years of Life, which will be presented by Professor Guilherme Polanczyk. After the presentation, those who have questions, please post them in the Q&A box, as we will have 10 to 15 minutes for Dr. Polanczyk to answer that. Dr. Guilherme Polanczyk is an associated professor of child and adolescent psychiatry, Department of Psychiatry at the University of São Paulo Medical School, Brazil. He is the director of the Child and Adolescent Inpatient Unit and of the Early Diagnosis and Interventions Program of the Institute of Psychiatry, Hospital das Clínicas at the University of São Paulo. He is also the director of the Research Center on Neurodevelopment and Mental Health at the University of São Paulo, the research director of the Department of Psychiatry, and the deputy director of the PhD program at the Department of Psychiatry at the University of São Paulo Medical School. Dr. Polanczyk has teaching activities with the undergraduate and graduate students, and is a clinical supervisor to residents in child and adolescent psychiatry. He has 20 years of clinical activities assessing and treating children and adolescents with mental disorder, particularly ADHD. His research interests include epidemiology, early manifestations, and interventions of ADHD, and have contributed with highly cited articles in the field. His work has been funded by NARSAD, CNPq, FAPESP, Grand Challenge Canada, Bill and Melinda Gates Foundation, Open Society Foundation, Fundação Maria Cecília Souto Vidigal, Lehman Brazil Research Fund, Wellcome Lip, and was recognized by awards from Brazilian Psychiatric Association and the American Academy of Child and Adolescent Psychiatry. He has occupied editorial roles or has been part of the editorial board of main journals in the field. He has approximately 180 papers published in peer-reviewed journals, 28,000 citations, and H-index 42. He was listed in 2018 as a highly cited researcher by Clarivate Analytics. Professor Polanczyk.
Thank you, Ricardo, for being here, for open the space in your schedule to be with us in this session. I believe this is a really important session, not only because of the topic, which I believe is highly significant in terms of scientific advancement, but also in terms of clinical care of our patients. So there is a major gap in how we understand ADHD in the first years of life, and this is the topic I'll be talking in this session. This is my conflicts of interests that are related to the topic of our conversation this afternoon. So what is behind the idea that ADHD emerges early in development? Well, first of all, we know that ADHD is highly heritable. It is among the disorders with higher heritability rates. These genes that are underlying the risk for ADHD and environmental factors, they are in fact shared with other neurodevelopmental disorders, and autism spectrum disorder is probably one of the most important in this context. There is a genetic correlation with ADHD that is about 0.4, 0.5, so it's highly correlated. But it is correlated not only with neurodevelopmental disorders, but also with other mental disorders, like depression, for example, and with cognitive functions. So we have genes, we have environmental risk factors shared with other disorders and concentrated early in life. So we have prenatal and antenatal periods that are marked by factors that increase the risk for ADHD. There is a discussion on whether they are causal or just association, and we can talk about that later. So with a strong genetic risk, with risk factors that are those concentrated in early life, the idea is that etiological mechanisms associated with ADHD, they are acting, they are developing years before the age at which symptoms can be reliably measured. And if we identify early mechanisms that are underlying the emergence of ADHD, this is a road to preventive interventions. We have several interventions nowadays that are focused on this early period of life, but these interventions are not specific, and it is a very complicated theme to develop and to test interventions. At this age, there are non-specific. So if we could understand mechanisms, this would enable preventive interventions that are more targeted. And this is, of course, to reduce the incidence of impairing levels of ADHD, but also other conditions. So this is one work by Megan Miller from Mind Institute, showing that infants actually from 12 to 24 months who have a sibling or a parent with ADHD, so infants with high genetic risk for ADHD, they are actually distinguishable from individuals from infants with low genetic risk with ADHD at age 12 months, 18 months, and 24 months in terms of inattention and activity level. So in this graph, you see on your left inattention, on the center out of sit, so moving and grabbing things, and impulsivity. And these are measures that are not limited to the parental report, but this is actually clinicians observing children. And as you can see, children with high genetic risk have already at age 12, at age 18 months, higher inattention, and also 24 months. And this is also true for hyperactivity and impulsivity. We conducted a systematic review and meta-analysis to understand what are the predictors of ADHD early in life. And we reviewed the literature, and several predictors were identified. So lower cognitive ability, language ability, and motor ability in the first years of life predicts ADHD. More problems in terms of sensory problems, activity level as well. Here, inattention and inhibition also are predicts ADHD, and also other cognitive measures such as reaction time and intra-individual variability. So these are non-specific predictors. Several of them are also predictors of other neurodevelopmental disorders, such as language disorders or ASD, but these can be already identified in the first years of life in these children that later will develop ADHD. This is an important study that evaluated the association between hyperactivity level at age 3. I'm not talking here about diagnosis, but hyperactivity level at age 3, and the association of economic burden at ages 14 to 25 years. This is a study by the group of Edmund Shonuga-Bark. And as you can see here, children who were classified as hyperactive at age 3, when they are young adults, there are more costs in terms of mental health, costs in terms of educational system, costs in terms of criminal justice, and also family, and also total costs that are much higher in relation to those children at age 3 who were not classified as hyperactive. So each 1 unit increase in the hyperactivity score at age 3 added a cost of approximately 50 pounds to the average individual cost per annum after adjusting for other factors. So this is very important because as we have a disorder or a symptom at age 3, there are non-specific actually to ADHD. It's highly predictive of ADHD, but it's not specific to ADHD. So this is really important as a marker, not only of ADHD, but problems and associated costs later in life. Based on the broad literature, there is growing. It is broad, it is growing, but it's still, we don't know lots of things. But based on this literature that has been accumulated, and we reviewed this literature in a paper published in JCPP Advances later to 2023. I'm sorry, but this reference here is outdated. So this paper has been already published, and Megan Miller is the first author. So we reviewed all the literature surrounding the developmental cascade. And we understand that all starts with genetic susceptibility. So the genetic risk is really important for the development of the disorder. There are some evidence that epigenetic mechanisms and may influence what we call fetal programming, and also gestational inflammatory process has been studied a lot, and there are some evidence that are associated with ADHD. We have prematurity and low birth weight as among the most important risk factors for the disorder, and there are some evidence for causality. There are some evidence from Mendelian randomization studies that does not demonstrate causality, but so far these are the most strongly risk factors associated with the disorder. It is likely that sensory and motor processing abnormalities in the first years of life may be related to ADHD, and probably here is disruptive sleep patterns and probably here regulation rhythms, impairment in these rhythms may be also associated. Temperament is one of the measures that is highly associated with later ADHD, and there are good evidence coming out on the association and including the longitudinal association. But in the first year of life, emotional reactivity, and not only in negative, not only angry, but also positive emotions are strongly associated with later ADHD, and problems in thoughtful control that is very overlapping. The measure is really overlapping with ADHD symptoms, but problems in this dimension are identified during the third year of life. So first, emotional reactivity. And of course, quality of parental care. There are good evidence demonstrating that maltreatment, that some specific dimensions of care interacting with temperament, for example, increases the risk for later ADHD. So the idea here is that once we demonstrate, once we understand the mechanisms underlying this process, maybe, as I mentioned before, maybe we can think of developing in preventive interventions. Or maybe before of that, we can think of more valid ways of early identifying these children that later will develop ADHD. And this is one of the focus of our research group. Because ADHD will manifest, and when it manifests, we understand that there is a chronic trajectory. And more moderate or severe cases of ADHD can also be diagnosed, can already be diagnosed at preschool ages. So in the United States, nearly 1/3 of all children with ADHD actually receive the diagnosis before age 6 years. And this is a marker of more severity. So half of the cases with severe ADHD were diagnosed by age 4. So children ages 3 to 5 years, approximately 30% of them in the United States in these two studies had mild symptoms, 41% moderate symptoms, and 30% severe symptoms. And this is really important. Already at preschool ages, about 60% of those children diagnosed with ADHD have already one comorbid disorder. So in our clinical settings, when we diagnose a child with ADHD, the follow-up studies indicate that these children, that 80 to 90% of these children will still have ADHD in school age years. And virtually all of them will have a mental disorder as in the school age period. So the diagnosis in clinical samples of ADHD has a consistent predictive validity for symptoms and also for impairment in adolescents. We understand that hyperactivity has an adequate discriminative validity, whereas inattention is not so a symptom that is not so useful in terms of discriminate in the future who will have and who won't have ADHD. And the intensity of hyperactivity symptoms seems to be the strongest predictor of future diagnosis and also negative outcomes. So of course, this is a difficult diagnosis. ADHD is a challenging diagnosis at all ages, and especially at this age, at preschool age, because we always have to differentiate what are symptoms from what would be normal development. At this age, adjustment disorders and stressors, family conflicts, and so on have an important impact on children's behavior. So we must be aware of these risk factors and stressors. Autistic spectrum disorder is a very important differential diagnosis, and sometimes they are comorbid, sometimes it's not ADHD, but ASD. Oppositional symptoms may actually be manifested by some hyperactivity or impulsivity, and this is something that also can be comorbid and is highly comorbid. And intellectual disability, of course, this is really, really important, and we know that the number of children with intellectual disability in the population is huge, and these children usually don't access services or don't have appropriate diagnosis. So the clinical manifestations of ADHD at this age: restless, cannot sit still, and sometimes families report that even while watching TV, these children cannot sit still. They are jumping, they are running. Sometimes parents will tell us that they don't stop talking, they don't stop moving, they don't stop going everywhere, and they are quiet only with electronics. We know that there is an association between screen time and ADHD at this age, an association, not a causality here, but association, and these children are increased risk of use of electronics. So difficult waiting in car traffic situations for a medical appointment, exposure to risky situations. We know that accidents are very frequent at this population, and specifically in preschool children. Irritability and temper loss are very frequent. We know that they are not part of the diagnosis of ADHD, the diagnostic criteria, but they are very frequent. And as I mentioned before, inattention are usually not a concern for parents, but they are frequently present. And when we investigate that, parents can tell us that the child cannot listen to a story. So parents start talking or start telling a story, and the child start talking or paying attention to a collateral focus of attention, does not complete a game or activity. Sometimes when children are taking turns while they are waiting for the other turn, they are already doing another thing. So these symptoms are already there. And social impairment is really frequent and really important, and not only for the child. There are good evidence showing impairment and social impairment at this age, but also impairment for the family. So this is one study that we conducted, and these are the rates of comorbid disorders. So 40% of them with ODD, 30%, 25% with specific phobia, and only 34% of the sample with no comorbid disorders. This is also data from our study, and this is a measure of disruptive behaviors. And as you can see here, children with most of days, every day, or several times a day, action can. I'm sorry. I will resume presentation. I'm sorry. So what happens also for these children is that a very disturbing home environment. So this is a measure of chaos at home. So as you can see here, 40% of the sample has many conflicts at home, parents for about 50% of the samples say that they are not in control of things at home or does not have a regular routine at home. And these are maltreatment measure. And so we can see here almost 100% of the sample of the parents said that they shouted, yelled, or screamed at the child. We see here hit him on the bottom with something like a bat, hairbrush, or stick, 20%, call him dumb or lazy, 36%, slapped him on face, head, or ears, 16%, beat him up, what is you over and over as hard as you could, 4%, said you would send him away or keep him out of house, 6%. So these are really high numbers for this population of children. So in terms of treatment, what guidelines tell us? So clinical guidelines, they suggest that parent management training is the first line intervention for preschool ADHD, and this is for a minimum of 8 weeks. And this is very important, as I just showed you how frequent are malpractice practice that are disturbing or inadequate from parents. So this is absolutely important. NICE guidelines supports parent training and contraindicate actually pharmacological treatment, and they suggest to refer to tertiary services if pharmacological treatment is considered. The American Association of Child and Adolescent Psychiatry is a bit more flexible in terms of medication and indicate that if there are persistent and impairing symptoms, methylphenidate is indicated. And if methylphenidate is effective, it should be used for at least 6 months and then discontinue to reassess underlying psychopathology. And if the methylphenidate trial is unsuccessful, we could switch to amphetamine formulation or alpha agonists or atomoxetine. Actually, the evidence for atomoxetine is higher than the evidence for alpha agonists. And despite this recommendation of treatment guidelines, what is the current scenario in terms of treatment of preschool ADHD? So US national estimates tell us that 76% of these children receives medication, 55% receive psychological treatment. There are rates of use of antipsychotics that they are increasing worldwide, and ADHD is a major indication for antipsychotics, despite there is no evidence whatsoever for ADHD, for the treatment of ADHD, and including in young children. And there are good evidence showing that actually sometimes clinicians prescribe antipsychotics before prescribing methylphenidate or other stimulant for children, preschool children with ADHD, which is a completely nonsense. Globally, preschool children with ADHD are inadequately treated or no treated at all because there is this limited access to treatment and the underlying evidence is weak. So parent training, we understand it's really important, and considering the oppositional symptoms, considering malpractices, they are really needed. But these are the usual targets of parent training, and there is good evidence that parent training will help on these targets. So the effect on oppositional and defiant behavior, they are theoretically, and the evidence shows that they are positive, more plausible than the effect on attentional ability or motor control. So as we understand how ADHD manifests and the underlying biology, we understand that it's really difficult that by training parents in how to best manage or best interact with their children, that this will result in an increase in attentional control that these children will demonstrate during class, for example. Also, cost, availability of trained professionals are important constraints in several settings. And parental adherence and understanding may be significant barriers in different settings. For example, here in São Paulo, sometimes families need 1 hour, 2 hours to reach the hospital, for example, and these interventions are not readily available in primary care settings close to their homes. So these are important barriers. And also the evidence in terms of efficacy shows some important issues here. Here on your left, this is parent reporting ADHD symptoms after parent training. And as you can see here, there is an effect size of 0.512. So there is a moderate effect size for parent report of ADHD symptoms after parent training. But when, as an outcome of the randomized controlled trials, we have independent assessment of ADHD symptoms, not dependent on the parents reporting the symptoms, because parents are not blind, because of course they receive the parent training, so they are not blind to the treatment they received. So it's important to have independent assessment. And when we have this independent assessment, the effect size is not significant. There is no effect actually of the parent training in reducing ADHD symptoms. So this is really important because maybe it's not effective. And on the other hand, there are evidence for stimulants. PET's study was the first one to assess methylphenidate, and in comparison to the effect of methylphenidate on school-age children, the effect size is smaller, so theoretically it would be less effective, or the magnitude of the effect is less than in school-age children. There are higher rates of adverse events and higher peak plasma concentrations. So only 22% on best dose with methylphenidate had excellent response, 13% on placebo. But this study has problems specifically because 32% of the sample dropped out, and 45 on placebo and 15 on methylphenidate. So it's really difficult when almost 1/3 of the sample is not retained on outcome assessments. And in phases 4 to 7, moderate or severe adverse events in 30% of the sample. But there are other evidence that are a bit conflicting. And this is a study that assessed safety of long-term treatment with standard-release methylphenidate in preschool children. So this is 52 weeks following these children with methylphenidate long-acting, extended release, sorry. So about 90% of adverse events were mild or moderate, only 1 serious adverse event, and 10 children discontinued because of adverse events. So considering this scenario of some weak evidence on parent training, some problems in terms of the studies showing the efficacy and safety of stimulants, we in our group, we conducted a randomized controlled trial testing methylphenidate and testing behavioral parent training for preschool children. This study, the primary outcome results was published late 2022 in Lancet Child Adolescent Health. So what we did in this study, there were 3 groups. The first group received methylphenidate, so this is the active treatment, methylphenidate medication, and they received a sham behavioral parent training. So they received an intervention that seemed like behavioral parent training, but wasn't behavioral parent training. I'll explain to you later. The second group received placebo medication. So they got pills, exactly the same pills that children on methylphenidate received, but they were placebo, and they received behavioral parent training. And a third group that received only placebo and sham behavioral parent training. So this is the comparison group. So these were preschool children with ADHD diagnosis. They were symptomatic. They were at school or daycare center. They had an IQ higher than 70. Children with major clinical conditions, autism or affective disorders were excluded. Medications during the previous 30 days were also not allowed. And we needed a main care representative who were capable to understand the objectives and also the parent training, the behavioral parent training. So the first intervention, as I mentioned, was methylphenidate twice a day for 8 weeks. We started with 0.3 milligrams per day and were titrated up to 1.25 milligrams. So this were a regimen that was suggested, but were flexible. So if there were adverse events, methylphenidate, the dose could be reduced or not increased. Behavioral parent training was the helping the non-compliant child. So this is an evidence-based behavioral parent training. Can you confirm if you can hear me, Ricardo?
I can.
Okay.
I can hear you.
Great, thank you. So let's hope here. So the behavioral parent training, as I mentioned to you, and the SHAM behavioral parent training, which was an education intervention, the same format, and we addressed developmental issues. So parents weren't aware that that specific intervention had no active ingredient, no behavioral ingredient in this intervention. The primary outcomes were ADHD symptoms, CGI, so clinical severity, global functioning, and we had secondary outcomes, so cognitive functioning, irritability, and disruptive behaviors. And adverse events were extensively assessed, including lab and ECG. So this was the design of the study, and we had 153 children randomized, 51 for each group, 84% boys, IQ 90, only 9% discontinued treatment and none because of adverse events. 93% completed at least 7 of 8 sessions, either behavioral parent or educational intervention. So they really got the intervention, and 134 received the maximum dose, 1.25 milligrams per day of methylphenidate, representing about 27 milligrams per day. So they really got the interventions. What we have here is over time in methylphenidate, a reduction of ADHD symptoms here, and on behavioral parent training, also a reduction of symptoms, and on educational treatment, there is, we can see here that reduction is really low of ADHD symptoms. And when we compare methylphenidate with placebo, we have here, with behavioral parent training, there are no differences in terms of the effect of methylphenidate and behavioral parent training in terms of ADHD symptoms, CGI, or CGAS. The effects appeared on methylphenidate comparing with placebo, so we have a significant reduction of ADHD symptoms, reduction of severity of the disease, and improvement of global functioning. And when we compare behavioral parent training with placebo medication, there is no effect in terms of reduction of ADHD symptoms. There is a marginal effect in terms of CGI, and the only effect that is significant is improvement of global functioning with behavioral parent training. What happened here is that we did not, I'm anticipating here, we were powered to comparison with the control group, but we did not have power to compare to active interventions. So these are the primary outcomes. This is just the graphic representation of what I just showed to you. And in terms of secondary outcomes, this is really interesting. Methylphenidate group had better performance than placebo and behavioral parent training in detectability in reaction time. Behavioral parent training had greater reduction of irritability, and also behavioral parent training had greater reduction in temper loss in comparing to the other two groups. Adverse events, they were more frequent in methylphenidate, but they were mostly mild, so decreased appetite and insomnia, and reduction of body weight occurred in this group. We have here lab and ECG, no alterations, no problems in children receiving methylphenidate. So in summary, methylphenidate led to a reduction of ADHD symptoms and to improvement in global function in comparison to placebo. Behavioral parent training produced improvement in global functioning. The secondary outcomes indicated, as I mentioned to you just now, specific effects for each treatment. And methylphenidate was associated with more mild adverse events. So considering this study, we conducted a systematic review and meta-analysis of stimulants, not only methylphenidate, but including here lisdexamfetamine. And what this meta-analysis showed with 5 studies is an effect size of 0.6 of stimulants for stimulants with a moderate quality of evidence in terms of reduction of ADHD symptoms. And we have here discontinuation. The rates of discontinuations weren't significant, but the quality of evidence here is low. So we have from our individual study and from this meta-analysis, the evidence that effect sizes of stimulants.
Hello, everyone. First of all, thank you all for all your questions, all of them very interesting. I would like to explain, we are having some technical problems due to weather conditions. Here in Brazil, we are having awful tempests and mostly in São Paulo. That's the place from where Dr. Polanczyk is speaking. So we hope we solve the problem as soon as possible. And I'd like to say that we will have some extra 15 minutes due to the technical problems we are having, okay? In order to answer the questions and the discussion.
Can you hear me, Ricardo? I'm sorry for everyone who is with us here. What happened is that the power in São Paulo just stopped here, and the internet provider, which I will not tell you which is my internet provider also, so I'm here using my secretary internet. So I don't know if we could maybe address some questions, Ricardo, that probably several people have already left, but for those who are still with us, maybe there are questions that we could address.
Yes, I will choose some. How to differentiate between ADHD and educational distortions at a young age?
When we are talking about ADHD, we are talking about symptoms, behaviors, impairments that are manifested across the context that the child is involved with. So if we are talking about problems that occur only at school, only in the context of educational activities, this is not ADHD. So we are talking about a broad disorder.
Okay.
Yes.
There are a lot of compliments here. And what is the neurophysiological mechanism for being quiet during screen time, yet rebound hyperactivity and impulsivity afterwards?
So during screen time is a very, as you know, engaging activity. This is an activity of high salience, and this is why the attention of the child is engaged. Of course, this is something that has been studied more and more, and we've been understanding the mechanisms, but I couldn't tell you the exact neurophysiological mechanism associated with that.
That would give you the Nobel Prize. Does the study also inspect the difference in gender differences? Does the signs and symptoms shows up the same for female infants as well?
This is a very important question. There is a huge barrier to young children, but also adolescents and women to reach services. Actually, more children and adolescents and less women, but still this is an issue at adulthood. So it is really important to recognize that that young children, women, girls, they tend to have more internalizing symptoms. We tend not to think about ADHD when we are seeing a child. This is some studies show that there is a stereotype behind physician's mind. So this is really important. In our sample, only 25% were girls, and this was broad. This was a broad procedure to ascertain also women, but young girls, but we could not assess. Sex, biological sex, was not a moderator, was not a variable that influenced response to treatment.
Okay. How early can we start with methylphenidates?
I think after a very careful assessment, and we are sure that these children has ADHD, after excluding differential diagnosis, after assuring that there is no maltreatment, there is a good home environment and practices that are adequate from the parents' perspective, once understanding the school environment is also adequate. If we have moderate to severe symptoms of ADHD, despite educational and despite psychosocial interventions, we could start at age 4.
What physical health screening is done prior to initiating stimulants to rule out cardiac and other medical contraindications?
Very, very important question. Nowadays, there is no suggestion that a ECG or echocardiogram would be necessary for those children who does not have any clinical symptoms. Clinical examination is innocent. There is no sign in clinical examination and no close family history of a heart problem. So in these children, there is no indication for ECG or other imaging or other methods. But of course, it is really, really important to follow up these children closely. So BP, heart pressure, we know that there may be a diastolic and systolic increase in blood pressure. So this should be monitored alongside with the growth of the children.
Which are the antenatal risk factors for HD&D? Drugs, consume, mom depression, physical or psychological disease?
So this all risk factors are associated with ADHD, but the big question is whether they are causal or whether they are confounded by genetic risk. The child who has ADHD received this adverse environment from their parents, but also received genes, and genes are correlated with these adverse events. So this is a big question and a difficult one to address in methodologically, but we are growing and increasing the evidence on that. And so the causality is higher for extreme neglect, and this is coming from the Bucharest study, and also from prematurity and low birth weight. But there are recent evidence that contradicts what we so far knew. Recent evidence showing that there may be no causal association between prematurity and neurodevelopmental problems. So this is a really important topic. And as I mentioned before, if we are interested in understanding really more specific mechanisms, we should advance on this matter.
Any hypothesis on the impact of weight loss on brain growth?
I'm sorry, Ricardo, I missed the problem connection.
Any hypothesis on the impact of weight loss caused by methylphenidate, for example, on brain growth?
Yes. So there is of course the impact of nutrition. So we know that stimulants decrease appetite. So this may be this may be a mechanism, but also there are evidence that methylphenidate may have an impact or effect on cartilage, on the specific sites of growth on bones. So this is still not clear, but these are the two main hypotheses.
The parent educational training is anyone that we know, such as Patterson's or Barclays?
So the strongest evidence goes to helping the non-compliant child. The Barclays, triple P, and these are the strongest evidence. Let me check if I'm missing any program here, but yeah, these are the strongest evidence. There is one study comparing, and there is also the New Forest parent training that was developed by Margaret Thompson and Edmundson Ugabart. So these are the most important ones with strongest evidence.
Your clinical practice on the front line of care, combined with refined academic research, had a welcome association between practicality and reliability. This is my comment. And here we have a very frequent question. What can we do for reduction of appetite with methylphenidate or atomoxetine? Mom's health.
So this is a very important adverse event and very frequent. We should target, first of all, it is important that the child and the family has a healthy diet. So sometimes what we see is that child is eating, but is not eating well, healthy. So it's eating ultra-processed food. And so it is really important to address sugar and food additives, which we know that may increase hyperactivity. There is a good paper by Edmundson Ugabart in New England showing that. So we should make sure that the diet is as healthy as possible, as nutrient as possible, to address and to have specific emphasis on times of the day that the medication is not working. So breakfast, dinner would be the preferable one. So this must be very well addressed by family. So eat together. So if we have a moment that is a family moment, and children is also with their parents, with the family, and this is a nice moment. So this will also increase the likelihood that eating is accepted and well and by the child. Of course, we have all the possibilities in terms of decreasing dose, stopping medication for specific days if there is a very huge impact on appetite.
Does early parenting intervention differs from pure ADHD or ADHD with destructive behaviors?
I'm sorry, can you repeat, Ricardo?
Is there a difference in the kind of intervention from AD&D and AD&D with destructive behavior?
So we need to understand if this is related to irritability, if this is related to more disruptive behaviors and maybe initial conduct symptoms. But of course, for children who has more ODD or CD symptoms, behavioral parent training will be much more important, extremely important, and we need that parents are very well, have very good skills in managing children. It's important to understand that stimulants has also an effect in reducing ODD symptoms. So this is a population that we know that is an increased risk for psychopathology over time. So yes, this is a very important population.
We have more questions. We have questions concerning to the PDF and PowerPoint, if they would be available. But I shall remember that the presentation, the recording of the presentation will be uploaded 3 days from today on the IACAPAP site. Okay, so we'll try to answer. There are more questions. We have answered most of them. Some are there are some suggestions of interventions and models of interventions and things like that. So
if I could comment on that, just a final comment on that, Ricardo, I think it's very important. We have several different interventions in terms of habits, in terms of physical exercise, interventions that are composed by different ingredients, very sophisticated interventions. But so far, we don't have strong randomized controlled trials testing these interventions. And we definitely need this kind of studies. These interventions are very expected and definitely will be very welcome by the field and by families. So they want as much as interventions as possible, and especially interventions that can be more acceptable and can promote development independently of ADHD or not. But unfortunately, we don't have these interventions tested by strong and rigorous randomized controlled trials. And we definitely cannot waste time in children that are in need of interventions. And we know that time is very important here. The cumulative problems of ADHD is huge, especially for these children who are severely impaired. So we cannot waste time, we cannot waste money. So money directed to health interventions, especially mental health interventions, are scarce all over the world. So the very little that we have, we need to make the most of it, and we cannot use in interventions that are not proved to be effective. So this is really a strong appeal that people that develop this kind of interventions or are interested in this kind of interventions, please test these interventions so we can adapt and we can offer them widely.
Perfect. Thank you very much, Professor Polanczyk, for this presentation. Thank you all for the participation, the questions.
And thank you again, Ricardo. Now I'm talking about the host, about from the vice president perspective. So thank you again, Ricardo, and I'm sorry again for you and for everyone who is with us. This is absolutely out of control, and this is a problem that São Paulo is facing since Monday. So I'd like to thank you again for being here with us, and this is another invitation for you who are willing to join us in the IACAPAP meeting in Rio de Janeiro. Ricardo is already there preparing things for us.
Yes.
So I strongly recommend that you register as early as possible. And I'm sure this will be a memorable event. So I hope to see you all and meet you all in person there in Rio. Thank you very much.
Thank you.